Hello everyone, thank you so much for listening in today. My name is Katie Dircksen. I am a first-year pharmacy resident at Cape Fear Valley Health in Fayetteville, North Carolina. And today we will be talking about pharmacy-guided procalcitonin ordering in adult inpatients with lower respiratory tract infections. I have no relationships to disclose at this time. And to start, we are going to talk about some background with lower respiratory tract infections and procalcitonin. So first, lower respiratory tract infections are the leading infectious disease cause of death in the world and the fifth overall cause of death. This includes pneumonia, influenza, bronchitis, among many others. Procalcitonin is an inflammatory marker. It's elevated during times of bacterial infection, specifically with lower respiratory tract infections. It does have a high specificity, and it rises within about 2 to 4 hours of inflammation onset. It peaks at approximately 24 to 48 hours, and it declines quickly at a predictable rate once the inflammation is resolved or the bacterial infection is resolved. A handful of studies looked at procalcitonin monitoring for patients with lower respiratory tract infections, and what they found was that initial procalcitonin guidance can decrease antibiotic use by 60 to 70% with these infections. Also, quick and predictable kinetics of that procalcitonin does allow for faster antibiotic de-escalation. And lastly, antibiotic therapy duration was significantly shorter if the procalcitonin algorithm was followed. Lastly, some background of Cape Fear Valley, where we conducted this research. It is a 670-bed community teaching hospital. We have about 350 patients with lower respiratory tract infection that are diagnosed from November to January. We are a Joint Commission certified for pneumonia. And we have had procalcitonin testing capabilities for over 5 years. However, there's no standardized protocol for when to order these procalcitonins. That finally brings us to our purpose for this research project. We will be looking at whether or not protocolized pharmacy-guided procalcitonin ordering and monitoring in adult inpatients with lower respiratory tract infections decreases the total antibiotic duration in days of therapy. Our primary objective for this study was to look at the total antibiotic duration in days. We had a handful of secondary objectives as well. First one was time to antibiotic de-escalation in days of therapy, prescriber acceptance of pharmacist recommendations, number of procalcitonin levels ordered, and description of pharmacist interventions. Our study was a single-center, quasi-experimental quality improvement initiative. Our study population included patients that were greater than or equal to 18 years old. They had to be admitted inpatient to Cape Fear Valley Medical Center between November 2018 and January 2019 for our control group, and November 2019 to January 2020 for our intervention group. They had to have a suspected or diagnosed bacterial lower respiratory tract infection that was identified from a generated list of diagnosis codes. And lastly, they had to be reviewed by our antimicrobial stewardship pharmacist or an internal medicine pharmacist. Patients that were excluded included patients that had CKD stage 4 or 5 or end-stage renal disease on hemodialysis, patients that were susceptible to increased inflammation, such as patients that were immunocompromised, patients that had recent burn or trauma or surgery on the current admission, patients with chronic infection and or concurrent infection requiring antibiotic treatment, pregnant patients, direct admits or transfers from other facilities, and antibiotics present on admission, medication reconciliation. Here's the procalcitonin algorithm that pharmacists would follow for patients that met inclusion criteria. This was again approved by our Cape Fear Valley P&T committee. As you can see, regardless of the initial level, we would always get follow-up levels. We would never recommend to discontinue or de-escalate antibiotics based on that initial level. When our interventions truly came from was the follow-up level that we will see on the next slide. Here's the continued algorithm that pharmacists followed. If the follow-up level was less than 0.25 or 80% decrease from that initial level, at this time we would recommend to de-escalate or discontinue antibiotics depending on the patient's clinical picture. Clinical judgment should always supersede these lab values, and our pharmacists always took that into consideration. If the value was greater than 0.5 or it wasn't decreased by less than 80%, we would recommend to continue antibiotics, and we would continue to follow the procalcitonin for a max of 4 levels. Moving on to our results and baseline characteristics, they varied quite differently between the control group and the intervention group. The control group had 75 patients, whereas the intervention group had 41. The age, 66.6 years old in the control group and 58.1 years old in the intervention group. 43% were male in the control group and 54% were male in the intervention group. Coexisting illnesses, there were fewer in the intervention group compared to the control group. And then infectious signs on admission, again, they were different between the groups. 36.8 degrees Celsius for control group on the temperature and 37.3 degrees for the intervention group. 11.8 for the white blood cell count in the control group and 12.4 for the intervention group. And 5 positive sputum cultures for the control group versus 1 in the intervention group. Next is our endpoint results. For total antibiotic duration in days, the mean days for the intervention group was 10, while the control group was 10.8. So even though the intervention group was lower, it was not statistically significant, resulting in a p-value of 0.34. As far as time to antibiotic de-escalation, in days of therapy, they were the same at 4.8. However, the control group did have a larger standard deviation, resulting in a p-value of 0.89. For prescriber acceptance of antibiotic discontinuation, only 33% of prescribers accepted this recommendation. For the de-escalation, however, prescribers accepted this recommendation 86% of the time. The number of procalcitonin levels obtained during the control group time was 29 versus 88 in the intervention group. A strength of this study was that we had an extensive amount of exclusion criteria, which really did minimize the occurrence of confounding variables in this population. However, we did have many limitations. First of all, we had a very small sample size, and it was a very heavy workload for the only few pharmacists that were working on it. And then lastly, the short length of hospitalization. While it was great for the patients not to be in the hospital longer, it did prevent us from following up the procalcitonin levels and making interventions. So at this time, expanding this program is likely not feasible with our current pharmacist workflow. To conclude, pharmacy-guided procalcitonin trending did not have a statistically significant difference in the total duration of antibiotics prescribed in days of therapy. I would like to thank my co-investigators, Dr. Bowers, Dr. Bryan, Emily Woodfield, and Dr. Tart for all of their help with this project, and also thank my study site of Cape Fear Valley Health System for allowing me to do this project. And lastly, we'll wrap up with a self-assessment question. What type of recommendation were providers most likely to accept? A, antibiotic discontinuation. B, antibiotic de-escalation. C, antibiotic reinitiation. Or D, antibiotic continuation. And the answer is B, antibiotic de-escalation. Thanks again for tuning in today. If you have any questions or comments, please feel free to reach out to me at my email provided.